Presentation before we begin our seminar. In 2008, Farron and Stena Anderson established the Anderson Diabetes Fund here in college for the purpose of assisting students doing research on diabetes. That fund has made possible the awarding of the Anderson Diabetes Research Award. We're pleased to announce that Megan Nicole is the first recipient of that award. Megan, would you come forward? Megan is an outstanding student, majoring in both physiology, developmental biology, and in biochemistry. Megan is the recipient of the most prestigious scholarship at BYU, the Thomas S. Johnson Scholarship. She's doing research in the lab of Dave Thompson on the LKB1 AMP activated protein kinase signaling system, which has become a target for development of pharmaceuticals to treat type 2 diabetes. So I'd like to congratulate you, Megan, on this.
Was that a check?
We've asked Megan to offer the opening prayer.
Our dear Heavenly Father, we thank Thee for this day and for all Thy many blessings. We thank Thee for this opportunity to study here at BYU and to grow and progress every day and to become more like Thee, little by little. We thank Thee for the opportunity to be in the seminar today, and we pray Thee that we can benefit more and learn just a little bit more and receive more enlightenment about Thy world and Thy creations, Father. And we thank Thee for all the many blessings and pray that Thy Spirit may accompany us throughout this day. And we say these things in the name of Thy Son, Jesus Christ. Amen.
We're pleased to have with us today Farron and Stena Anderson. Will you stand, Andersons? We're greatly appreciative of the donation that they've made to begin this fund. Thank you. We're pleased to have as our seminar speaker today Dr. Steve Edelman, who is a professor of medicine in the Division of Endocrinology, Diabetes and Metabolism at the University of California at San Diego. He is also affiliated with the VA Healthcare System of San Diego, serving there as director of the Diabetes Care Unit at the VA Medical Hospital. He graduated as valedictorian of the University of California at Davis Medical School. He received his internal medicine training at UCLA and completed the endocrinology fellowship at the Joslin and Leahy clinics in Boston. He's also done a research fellowship at UC San Diego. Dr. Edelman has strong interest in education and patient advocacy. He's the founder and director of Taking Control of Your Diabetes, a not-for-profit organization dedicated to informing and empowering people with diabetes to become actively involved in their own health care. He's been active academically, publishing more than 200 articles and 5 books. He's won numerous awards for teaching and humanitarianism, including the American Diabetes Association 2009 Outstanding Educator in Diabetes Award. Dr. Edelman is a shining example of one who lived by the motto on the sign at the entrance to the BYU campus: enter to learn, go forth to serve. He's shown that one person can make a difference, as he has assisted literally thousands of patients in better coping with their diabetes. Will you welcome Dr. Steve Edelman?
Well, thank you very much for that nice introduction. I didn't think you were going to leave me any time for my presentation. Well, I'm happy to be here. It's my first time I've been to BYU, and I'm excited. I get a little tour later on. I get to hear the Tabernacle Choir practice tonight, and I have lots of Mormon friends, and some of which are here today because they came here when they were an undergraduate. So I appreciate being able to speak to all of you. Now, this lecture is not a heavy-duty basic science lecture. It'll be quite a different type of lecture, talking about really some of the important aspects of how you can help people with diabetes. And it's not just drug development and developing devices. It's really trying to get people with diabetes to put that on their higher on their own priority list. How many people here know someone or have diabetes yourself? Raise your hand. Okay, so there you go. I mean, so hopefully you'll pick up stuff. It's not a lecture to take notes on. So just kick back and relax, and I'm probably going to take the whole time, but I'm going to stay here afterwards as long as I need to if there's any questions. The other major point about this lecture is that we also have to educate the providers that take care of these people, because many of the providers don't understand how hard it is to live with diabetes, and they label their patients as non-compliance. And then they develop an attitude towards their patients, and it sets up a really bad negative catch-22 situation. And so through the years of working with university, with professionals, and then this not-for-profit organization, I've come to realize that some of the most important things that we can do to improve diabetes care is really to educate and motivate people with diabetes to take a more active role in their condition. Okay. Just to give you a little bit of where we're going in terms of the epidemic of diabetes, this slide shows the prevalence of diabetes in 1990. And in states that are white, that means there's no data yet back in those days. But the darker the blue, the higher the percent. And then if the state is in red, it's more than 6% of the population. So that's 1990. Here's the year 2000. You can see we've come a long way in terms of the prevalence and incidence is increasing dramatically. Now, not only in the United States, but also around the world. Here's 2010, where we have 10% of the population. And if you're a bean counter and you're worried about the healthcare dollar, it's estimated over $218 billion a year to take care of people with diabetes. Now, here's the issue. Most of this money goes into taking care of the end-stage complications: heart attacks, strokes, amputations, dialysis. We call that the end stage. And very little money is put towards education and prevention, which can prevent these end-stage complications. And that's the problem with our healthcare system. You're forced to pay for someone that goes into kidney failure, but you're not forced to educate them early on when they're healthy. And this just came out from the Centers for Disease Control, that if the prevalence continues as it is today without any changing, then in the year 2050, 1/3 of the population is going to have diabetes. This is the way I look at it, since I like football. But if this whole stadium, if this was 2050, this is the amount of people who would have diabetes in that stadium. So it's a pretty serious condition. And we're seeing not only an increase in adult onset or type 2 diabetes, which is the most common type, but we're also seeing a dramatic incidence in type 1 diabetes, which is the type that I have, and I'll talk a little bit more as we go through. So, we hear all these horror stories about diabetes, that yes, it's the leading cause of heart disease, kidney failure, blindness, and amputations. These are the statistics that we hear. And people with diabetes get pretty scared when they hear these things. But what they don't point out is that it's poorly controlled diabetes. And no one ever talks about what well-controlled diabetes is the leading cause of. And the answer is absolutely nothing. So it's really an important message. Diabetes is a treatable disease, but it's also not an easy disease to live with. And the requirements that the healthcare profession puts on people with diabetes, it's a long laundry list. And that's the issue. Many of the professionals don't understand, and that's when they develop an attitude towards their patients. And there's a lot of emotional barriers that get in the way if you have diabetes. One thing I'm noticing about BYU, there's a lot of Mac users here, so that's good. So we've had a lot of advances in the years. We've had meters, glucose meters. We have pumps, insulin pens, designer insulins, where we tweak the normal insulin to make it work faster or longer. But still, despite many advances, diabetes control is still poor in this country. And it's been estimated that well over 50% of the people with diabetes are not reaching their goals for control. Their blood sugars are not at the desirable range. the blood pressure is not good, the cholesterol is not good. So why can't we get there? There's a whole list, and this is not an exhaustive list. This is just things that I've thought about through the years. One thing is there's delayed diagnosis of diabetes and public unawareness. That's a big deal. There's poor diabetes care, and I don't want to say, I think the best way to describe it is uninformed caregivers and bad healthcare policies. I've never met a doctor or a nurse practitioner that went into medicine because they don't like patients, they don't want to help people. The problem is they're uninformed. They're not uncaring, but they're just not knowledgeable about all the advances in diabetes. There's lack of effective prevention and treatment strategies, as I've talked about earlier, and there's a lot of disparities in care and access to care. You can have the best devices and drugs in the world. You can't get them because you're poor, you don't have insurance, or your healthcare plan is too restrictive. Then what good is all the research that we put into developing these tools? And then a big part of what I want to talk about today is there's lack of patient education, motivation, and self-advocacy, because this is a condition where people who have diabetes have to live with it 24/7. And they need to be the most educated than anybody, including their healthcare team. The healthcare team helps them manage their diabetes, but they have to be the most knowledgeable. So in 1995, I started an organization called Take Control Your Diabetes, and I want to give you a little story about it, historical background, and bring you up to our professional Making the Connection program. So I have to show you my high school ID card because I got diabetes in 1970. This is the most embarrassing part of the talk. But there's me in high school. I came down with diabetes. I had all the classic symptoms of type 1 diabetes. Used to be called juvenile onset. And thirst, urination, weight loss. And it was something that I didn't know anything about. And this slide is from 1970. This is I scanned this from the educational booklets that I got. And this is how they manage diabetes. First of all, look at this diet. Steak with a bunch of fat on the outside, whole eggs, canned green beans, whole milk, and Wonder Bread. That was the diet. And of course, pills and insulin. Look at, as a 15-year-old boy, I'm sitting in this class, the diabetes education class in the hospital. Most people with diabetes were the adult onset, we call type 2. So I'm in this room, a pretty ignorant and naive teenager, and then about 30 overweight adults, and they're talking about diabetes, and I was thinking that, I look at this slide and all I could stare at was this needle right here. Look how big it is, and I remember one thing from that class, that ketchup has a lot of sugar. And I don't know why I remember that, because I use a lot of ketchup in my French fries. And I was thinking, even back then, that this wasn't the best learning situation, because they lumped everybody together. And I thought, gee, there had to be a better way. So when I first got diabetes, it was pretty archaic. This was my urine test kit, where I would pee in a cup, put 5 drops urine, 10 drops water, and then you put a glucose tab in your, and it would basically turn all kinds of colors, and you would hold it up to a chart, and the only thing you put in your logbook was +1, +2, +3. And don't forget, whatever sugar shows up in your urine was in your blood 3 hours prior. So it's very archaic. They didn't have any glucose meters, and nowadays I'll show you pictures of modern glucose meters where you could put a strip in a device like this and get a blood sugar, an actual number, in 5 seconds. We didn't have the A1C test. The A1C test is a very important test that we use in clinic. I'll refer to it a lot during today's talk. It's a blood test that tells us what the average blood sugar has been over the past 3 months, because you can't test your blood sugar every minute. We use that to monitor how people are doing. And so at that time, when I was diagnosed, no one really told me what the goals of control were for, and they didn't tell me why it was important to control my blood sugar. So over time, I did everything right at the beginning. I weighed my food out. My mother was very involved in my care. But as time went on, my control slipped. And this is another picture of me when I was diagnosed with diabetes. People say this is me, Spanky, over here. But, and my control started to slip. So I used to go to my doctor, who was just a general physician, nice guy, didn't know anything about diabetes, and every 3 months I'd go in, they check my urine for glucose because they didn't have the A1C test. And he'd say the same thing to me every time. Steve, you're doing fine. I'll see you next time. And I realized that I wasn't doing that well because when your blood sugars are high, you get thirsty and you urinate a lot. And I was a counselor at this boys camp. And you know, guys at boys camps do crazy things, right? So we had a contest, and for lack of a better word, this contest was called the pissing contest. And you know, typical boys camp is who could urinate for the longest period of time. And we had a stopwatch. No, seriously, I figured that was probably appropriate. And so I won this contest week after week because my control was so bad. And next time you go to the restroom, think about this. I urinated once straight for 1 minute and 15 seconds because my glucose was so out of control. And I knew it was, but my doctor would say the same thing to me every time. So I went in there. One time I went, right before my visit, I went to Winchell's Donuts. And I wanted to test him, and I ate 6 donuts. And I turned in my urine, and I tested it in the bathroom with my little kid. It turned black in about 2 seconds, meaning it was just packed with sugar. So I'm sitting in the room, and he comes in, and he has his little clipboard like he always did, and he looked at it, and then he looked at me, and he said, Steve, he had the results of my urine test. He said, oh, and my blood test. He drew my blood for the glucose. He said, Steve, you're doing fine. I'll see you next time. So I realized that, you know, he didn't really know any better. He didn't make any changes, and that was the last time I ever saw him. Because I was smart enough to realize that, hey, I'm out of control, and he wasn't really doing anything different. Now, the sad part about this is that for the first 10 years of living with diabetes, my control was really bad. Blood sugars must have been 200-300 consistently. And as a result, I developed complications. And this is a slide of what it looks like if you're a diabetic and you have a vitreous hemorrhage. Because high blood sugars over the years causes diabetic retinopathy. That's a whole topic of another seminar. And when I had a vitreous hemorrhage, you bleed into the vitreous of your eye. And that's how the vision looked. Luckily, you know, the blood settles and you get your vision back most of the time. So that's the bad news. The good news is I did run into when I was an undergrad at UCLA, I ran into some very good doctors who got me under good control, and my problems have stabilized. So luckily, my vision's stable, and I can still drive. My friends say I'm a bad driver, but I still can see the signs. And so I went to UCLA. I ran into some very good doctors. Then I went to medical school at UC Davis. And when I went to medical school, you know, I remember sitting in a physiology class, and the professor says 15% of all diabetics die of kidney disease 15 to 20 years after their diagnosis. And I noticed all my classmates were kind of looking at me like, you know, giving me some visual sympathy, you know, which I didn't like. But that was a point where I said, okay, you know, I'm gonna dedicate my career to improving care for people with diabetes, and specifically on the education part of it. See, I was the valedictorian, and just to let you know, because I feel guilty about this, it wasn't because my grades were the highest. My classmates, they voted who they wanted to give the lecture. So I got voted, so I was valedictorian. I was using my Darth Vader props, and it was a lot of fun. So I went to the Joslin Clinic, where I specialized in diabetes. That's where I did part of my fellowship. If anybody that really wanted to become a diabetes specialist went to the Joslin Clinic. So there I am with my big fro right there. And then I became faculty at UCSD. Now, at this time, there was a very famous study. It was a government-funded 10-year, $140 million study called the Diabetes Control and Complication Trial. Now, what this trial was meant to prove, if we go through the effort of lowering the glucoses in our patients with diabetes compared to those where we did not, could there be a difference in complications of diabetes? Could we reduce eye, kidney, and nerve disease? And up until then, there was several studies. They were smaller. But you know, American medicine, you have to prove everything with a double-blind, placebo-controlled trial. But this study clearly showed that if you lower the glucose levels in people with diabetes, you could make a major impact. So that was 1993. So this is actually a brochure of the first conference that I put on for medical professionals. But things weren't happening at the community level fast enough. Caregivers were not changing their practice habits, even though we had the solid evidence that they really should try to get their patients' blood sugars better. So what were some of the barriers? You know, managed care was just starting to hamper proper medical care in a major way. I'm not sure if you guys have much managed care up here in this area. As a caregiver, I was fairly helpless in trying to fight the system because they didn't really care about caregivers. They could just get doctors anywhere. They just wanted to get their quote-unquote covered lives, and there was very little education directed to the people living with diabetes. So I think in 1995, you know, all the education was going towards professionals, and to educate patients, that was kind of unheard of at that time. And it was very slow. Remember that it takes 10 to 15 years to develop a good drug for diabetes. And then the major teaching institutions like UCSD, BYU, would educate the caregivers, and then each caregiver had a certain number of patients in their practice that they would try to influence. Now, many caregivers, once they get past their residency, it's been shown, it's very difficult to change their practice habits. So you can come up with the best studies and drugs in the world. If a caregiver doesn't go to continuing education programs, if they don't change their practice habits, then their patients, unfortunately, don't get the benefit of these advances. And this was, I thought, too slow a process. So I decided that in 1995, I think that we should all take the important messages about living well with diabetes directly to the people most affected. And those are the people living with diabetes. So I started this organization. This is the brochure of our very first conference in 1995. And we really wanted to focus on education, motivation, and self-advocacy. And since then, we've developed it into a national organization. This is the mission statement, guided by the belief that every person with diabetes has the right to live a healthy, happy, and productive life. TCOID educates and motivates people with diabetes to take a more active role in their condition. And this is really where the rubber meets the road. You've got to get folks to put diabetes high on their priority list. This is just a quick picture to show that we just finished last Saturday in Tucson, our 125th national conference. We've increased the number of conferences. Each year, we try to go to new cities. We come back to the same cities a couple years in a row. And we also try to lead by example. We try to get local doctors there to learn how to put on their own programs. Because we can't be in every city every year. It's quite an expensive process. And as a not-for-profit, you know, it's hard to raise money to put on these programs. So these are the important themes of the organization. And this is slides I use when I'm talking to patients, that you have the main responsibility for taking control of your diabetes. You are your own best advocate, and be smart and be persistent. And once again, getting people to take ownership of their condition was the challenge, and that's not easy. And I'll tell you what, I've never met a patient with diabetes who did not want to live a long and healthy life. But yet things get in the way. And there's a lot of emotional barriers: fear, guilt, anxiety. There's socioeconomic, financial barriers as well. So this is the brochure just from last Saturday, April 2nd in Tucson. And we've learned to refine the program through the years, and I want to tell you some of the secrets. This is just a picture. We get large crowds. I think we had close to 1,000 people at this conference in Tucson. And here's are some of the keys to a successful model: that we have a strong emphasis on motivation and removal of the emotional barriers. That's key. If you don't remove those emotional barriers early, people's minds aren't open to bringing in information. Strong and clear messages about how to live healthy with diabetes, and then we have these big general sessions like you just saw, and individual workshops, and I'll show you some of those as we go through. Well-defined and attainable goals. You have to be really careful about not asking for everything too quickly, and really focusing in on the standards of care, and these goals have to be clearly stated. And in the morning, the general session, everyone's together. We don't have time for Q&A, and that's why we have individual sessions in the afternoon where we have hands-on sessions and meet the expert sessions where people can talk about their own issues. We have a targeted audience: people with diabetes, and very importantly, their significant others. because these are the folks that are supporting them through the system. And we have clear action plan. Participants are guided to make realistic, and that's underscore realistic commitments to their health that day. Even if it's as simple as I'm going to walk around the block as my first step for starting exercise. So here's pictures of the general session. We have, and I always give the opening session. It's pretty much an overview of the day. I talk about general issues in diabetes. Very strong and clear messages. You can't miss that one right there. And well-defined and realistic goals. And I'm a big believer in humor, whether I teach undergraduates at UCSD or the medical students or patients. I'm a big believer that humor leads to information retention. It's much better than a boring lecture where it puts you to sleep. They maybe have great information. The information I give isn't rocket science, but I try to give it in a way where people pay attention. So, and I'll show you some of the slides I use with the patients. Now, this is just a picture of several glucose meters. These are the meters where you prick your finger, you get a little drop of blood, and you put it on a strip, and they typically give you a result in 5 seconds. And they're pretty accurate. So this is a big message to the people living with diabetes. One of the big barriers in care is that people do not test their blood sugars as much as they should. I mean, who likes to prick their fingers? Nobody. But it's important to learn how lifestyle affects their diabetes and the medications. But here's the joke, living with diabetes myself, on all these advertisements, why are the numbers always so normal? And then I show this slide. I say, I dare a company to come up with an advertisement that looks like this. A little voice thing comes up and says, darn. How about little sayings that pop up like, what did you eat this time? Here's my kid's favorite one. Oh, that's why you're acting irritable. They don't like what I'm saying. They go, Dad, go check your blood sugar. I'm motivated for why not make light of it? But to be serious about it, your home glucose monitoring is not just measuring and recording your values. It's really knowing what to do with a number and then taking action to correct it. So I'll tell you what, if someone tells you to test your blood sugar 4 times a day, every time you test it, it's high, but you haven't been given the tools to do your own self-management or to react to that number, you don't want to test either. Who wants to test 4 times a day, see how bad you're doing? And that's where the key comes in. I want to show you this guy's logbook. The numbers circled in red are all ending in 0. You see this person has 3 144s in 1 week. There's no food or blood. All the numbers are written with the same color pen. And the funny part about this is, this clinic was on the 8th, and on the 9th, you can see there's a number, like this is the future, and he crossed it off. So he was making up the numbers. And he went past the date, he goes, whoops, and he crossed it off. And didn't think I was going to notice. Now, it turns out we have this test called the A1C. His A1C was 15%, meaning that his average blood sugar over the past 3 months was 300. So he was making up the numbers. We call it dry labbing it. Now, a normal doctor would say, oh, this guy's a liar. He's a non-compliant. He makes up his numbers. He doesn't care about his diabetes. But what's happening here is the doctor should really look at himself and say, hey, I don't think I've developed a good enough patient-provider relationship that this patient either didn't test or the numbers were so high he was ashamed to tell the truth at the doctor-patient visit. So a lot of this goes on. So this patient's testing. Look at the blood that he's wiping on the sheet, And look, if you look at these numbers, his morning numbers are the highest of the day. Lunch and dinner aren't that bad. So as a provider, I'm trying to educate patients to say, okay, don't just test and bring it in and say, here's my result. You need to test for yourself primarily and look at these numbers and say, hey, my morning numbers are high. Now, patients have been trained to adjust their nighttime insulin to help out with that, but if you haven't been, at least say, okay, my numbers are high in the morning, my next clinic visit isn't for 4 months, I'm going to call up and talk to someone on the phone or get in earlier because I noticed there's a problem. And that's what taking control of your diabetes is all about, is to test for yourself primarily. So just to let you know, there's a lot of cool glucose meters. This is a Korean cell phone that's also a glucose tester. Here's a brand new thing that's going to be coming out. It's called the BGStar. This is an iPhone, and this little device is the first medical device approved by Apple. Snaps on the bottom, your glucose strip in there, and then you can test your blood sugar, and of course the number's normal. on the advertisement. And this is called the Bear USB. You can see it's a glucose tester, and of course the blood sugar is pretty good. And this sticks into your computer and gives you a nice software program to help you analyze your blood sugars. So it's not just looking at your logbook anymore. They have very nice software programs. And there's a whole bunch of iPhone apps for that too. My daughter comes home with this picture and says, "Hey Dad, look at this cool phone, it's got a rotary dial." She thought that was the coolest thing, you know, she's never seen that before. Now, the other huge advance, she's a freshman at University of Washington, Seattle. I really want her to come here. I think tuition's way cheaper. Now, this is a huge advance in diabetes. Huge, huge, huge. This is a monitor, which I have, called a continuous glucose monitor. And you put a little sensor under your skin, you do it yourself, you snap on a transmitter, and every 5 minutes, I get a new blood sugar. And you can put in your high and low alarms that alert you if you're getting too high or too low. And you could have a severe low blood sugar while you're driving, get in a car accident. Unfortunately, people pass away if they pass out from low blood sugar and they don't have help. It happens, not very frequently. And this also gives you a number, and it gives you a trend arrow. It has very sophisticated software that looks at the rate of change and can tell you which direction you're going. And then think about this. If you check your blood sugar at one point in time, it says 160. You don't know if you're going up, you don't know if you're going down. And I think this is one of the greatest advances for insulin-using patients since the discovery of insulin. And I don't go anywhere without my continuous glucose monitor. This is the setup. You can see this is the applicator. It takes literally 30 seconds to put in. You put it in, some people put their abdomen, I put mine in my upper thigh. Sometimes I do my abdomen, and then this applicator comes off, you snap in the transmitter. This is just an example of advances in modern technology, and this makes living with diabetes so much easier. And the other reason I wanted to show you this picture, because that's me. You don't believe me, huh? And I don't think there's a single person with diabetes that's on insulin, especially type 1, that would not benefit greatly. And here's the issue. Doctors don't know about it. Doctors are afraid of it because they think it's too much information. And patients don't know about it. So it's professional and patient inertia. And this is what we try to overcome at these conferences. Other issues that we bring out at these conferences is that, you know, people with diabetes have to be on a maintenance program, just like our cars. And we always talk about the ABCs. So it's not just A1C, which is glucose. It's getting on an aspirin. It's getting the blood pressure and cholesterol down. And that's true with every American. Every American should be really concerned about their blood pressure and cholesterol. You know, we talk about how to prevent blindness. It just comes down to the simple fact. Get a yearly dilated eye exam, and you will not go blind. You may have some visual problems. And why is screening so important? Because there are no symptoms of diabetic eye disease until there are advanced stages. Any condition that doesn't lead to symptoms, no pain or swelling, you're not going to go to the doctor because you don't feel anything. And that's why screening is so important. Cholesterol has no symptoms, high blood pressure has no symptoms, early eye disease has no symptoms. And I can almost guarantee anybody that if you go to the eye doctor once a year, get a dilated eye exam, you will not go blind. And that's a big issue, you know, and that's scary for a lot of people. Same with our kidneys. Get a yearly test of your kidney function. There's all these fancy tests. I don't have to get into details, but once again, there are no symptoms of kidney disease in the early stages. Now, sometimes what these patients have to do, what I have to do, is urinate in a jug for 24 hours. It's called a 24-hour urine collection. And the issue is you have to keep the urine cold for 24 hours, otherwise the test is inaccurate. So, you know, people have to, usually they try to pick a weekend where they're at home and you got to keep the jug in the fridge. And so I always tell people you have to label your jug very carefully. My kids come in, they drink right out of the container. That'll serve them right. Okay. And also, people with diabetes get a lot of tooth and gum disease because there's natural bacteria in our mouths, and if your sugar's high, people get really bad cavities, they get very bad periodontal disease. So I told them, this is my recommendations, tooth and gum disease are common. This is the actual slide I used. Brush twice a day, floss once a day, at least 1 week before and after you go to the dentist. Don't you guys get motivated? Otherwise, you're going to look like that. Now, some of the other issues in diabetes care, I'm just picking real specific ones. That this concept of this slide is for people with type 2. That their therapy may change over time. And, and even if they're doing everything right in terms of diet and exercise, they may need lifestyle and one pill, they may need other medications, they may eventually need insulin. And this is scary for a lot of people with type 2, and that's another big barrier. I told you, people aren't testing their blood sugars enough, and people with adult onset or type 2 diabetes, when the pills stop working, they have to go on insulin. And getting a type 2, 50, 60-year-old person to take an injection is really tough. And there's tons of pushback. And they have all these fears about insulin and the pain of these needles. And one of the things that we did as part of taking control of diabetes, we started a program called Extreme Diabetes Makeover. And this is a reality-based documentary that's going on, it's showing right now. I'll give you the website. But I want to tell you about a few of these folks. Renee is someone with type 2 diabetes. But what we did was we screened people at our conferences to be on this 5-month program where we videotaped the whole program, and they had to have 2 requirements. Your diabetes had to be out of control, your A1C was really high, and you had to have the desire to get better. And these people were not hard to find. And we exposed them to the dream team of an educator, an exercise physiologist, a diabetes specialist, very important clinical psychologist to get through the emotional barriers, and a dietitian. And I wanted to just show you the short video clip that describes the program.
We've talked about a program like Extreme Diabetes Makeover for a long time at TCOID. Our idea was to follow a small group of people with poorly controlled diabetes, both type 1 and type 2, from all walks of life for a significant period of time, like 5 months, and have them work with a dream team of diabetes care professionals. We wanted to see if combining care, focus, and commitment can help change them in ways to get their diabetes under control. We also thought that if we filmed the process, we could share it with others in ways that might help them control their diabetes and to realize that their struggles are not uncommon.
So it's really just about getting activated. And the definition of that for me is getting educated, motivated, and empowered to take control of your diabetes. And here's the website for our organization. It's also being shown on realage.com, which is a big health and wellness website started by Dr. Oz. And we follow these people over 5 months. Now, back to Renee. She's 55 years old, and she's got multiple medical problems. Look at her A1C, it's 11.6, meaning that her average blood sugar is 290. So we had to start her on insulin. So in the office, she didn't have any big problem with it. She didn't seem like she was afraid. So she brings back her high-definition home flip cam that we gave all the participants to do their home video diaries, to talk about things when they had successes and failures. So we download her camera, she leaves, and then we watch it later on. And this was a tremendous learning point for myself. When I saw what she was going through at home, I was totally unaware.
Started insulin 3 days ago. Anyway, I took the insulin, woke up at 3 a.m. because I was so excited to see my blood sugar, and it was 176, so yay, it was coming down because normally it's up in the 200s or so, so I couldn't wait to go back to bed, to wake up in the morning and take it again. So that morning I woke up, took my blood sugar, and it was 208. I was very disappointed. Very. Anyway, the next day, I took it again at 6 a.m. and it was 238 again, and I'm still disappointed.
So just the bottom line is, I must have told her 5 times, we're starting off with a low dose. We have to bring it up over time. Don't be disappointed if it's not down the first day you take insulin or the first week. So, but it's amazing, you know, what you hear at the doctor's office when they say you got to start insulin, and you don't hear anything else. But I thought that was pretty amazing. And And these are some of the clips that we show to professionals so they know what's going on with their patients at home. I'm not going to talk too much about this guy, but he's a lawyer. I don't typically like to help lawyers. But he's, of all 7 participants, he had the highest level of education, he was the wealthiest, and he had access to the best health care and was seeing a very prominent endocrinologist in San Diego that I know well. Look at him. He had the worst control of anybody in the entire group, including one of the guys that I'm not going to talk about, who was a homeless guy. Now here's this smart, educated, wealthy individual walking around with the worst control. And how do you figure that? He's a grandfather. He doesn't want to die early. And that's what the whole issue is about diabetes care. He just has put it low down on his priority list. So I usually finish my morning talk with a poem specifically written for people with diabetes. And here it is. If you can be cheerful ignoring aches and pains, if you can resist complaining about your troubles, if you can eat the same food every day at the same time and be grateful for it, which is what we ask people to do, if you can understand when loved ones are too busy to give you attention, if you can take criticism without resentment, if you are always willing to exercise at a moment's notice, then you're probably the family dog. Think about it. But, so I say, we should be more like our pets. Like that. Like that. How about this one? And my next one is my all-time favorite. Here it is. So let me take you through the rest of the day. Okay, the second lecture, right after myself, is a clinical psychologist. And once again, if you don't get through those emotional barriers and take away the fear, the guilt, anxiety early, then these folks, their minds aren't as open to pick up new information. We have lectures on food. And this is one of the best lectures I've ever heard. Are you what you eat or how much you eat? And it turns out when you have diabetes, you can pretty much eat anything you want. It comes down to portion control and eating the foods you like in moderation. You want a juicy hamburger? For God's sake, have one once in a while. This happens to be a 5-pound hamburger at a store in Cincinnati, Ohio, and if you eat the whole thing in the first hour, you get it for free. So this is a great video clip. You know, diabetics aren't supposed to eat greasy, fatty foods like potato chips, and I thought this was just perfect, and the crowd loves this commercial. Think of bright colors when you eat, like greens, yellows, and reds. It's very simple. You know? So at these conferences, these folks are in the majority, not the minority. This is lunchtime. And people sit with each other, they talk to each other, and they realize that they're in a place where they're the majority. They also realize that diabetes crosses all socioeconomic boundaries. And so the lunchtime is very important, and we design with our caterers, the chef at the convention centers, to design this lunch has to be good, but it has to be healthy. So that not all diabetic food should taste like cardboard. At lunchtime, we have a motivational speaker, Billy Mills, very famous Native American. He's the only American ever to win the gold medal. Very big upset at the 10,000-meter race in the '64 Olympic Games. He shows a video clip of the announcer where he did this huge upset. He was a total no-name. And chills go down my spine every time I hear him speak. Della Reese, we have basketball stars and sports, and having an African-American guy who has diabetes, great role model for these young kids. This kid doesn't have juvenile onset type 1. He has adult onset diabetes at the age of 8. Both his parents have type 2. That's why they changed the name from adult onset to type 2. You can get any type of diabetes at any age. This is the most motivational person I know. He's my patient. He's a Vietnam vet. He spoke at Tucson last week. The title of his talk is "Diabetes Saved My Life." That's a picture of him when he was a platoon sergeant in Vietnam. And I don't have time to tell you the story, but he was coming down with diabetes. He was getting sick. The people at sick call said he was just trying to get out of action because he was afraid of being killed. And they threatened to court-martial him. So he lost about 60 pounds from undiagnosed diabetes. And he was going, his whole platoon was ambushed. And every one of his platoon was killed. He passed out from undiagnosed diabetes. Enemy thought he was dead. So they put him in a body bag, and all the other guys, they shipped him off to be identified, and when they unzipped his bag, it's kind of a gruesome, sad story, but the guy, they found the guy who unzipped him, and the first thing he noticed, there wasn't blood or body parts in the bag. But the guy Urban was still breathing. So from that point, they got him to a hospital, and he survived. And the title of his talk is "Diabetes Saved My Life." And he's done tremendous things with his life. He's blind now, and he has a kidney transplant, but Agent Orange also accelerated his complications. But don't feel sorry for this guy. I mean, he runs 2 not-for-profit organizations. He's very successful, and he's probably he is the most motivational person I know. So we try to get people at lunchtime that they can talk to afterwards and give them motivation as well. We also had Nicole Johnson, who was former Miss America, used to walk down the little aisles that they do during their pageants with her insulin pump. She brought diabetes out of the closet in a major way. We always have legal people speak. This guy, Chris Halpern, he's a type 1 diabetic. He's also a lawyer specializing in the rights. And we try to help people pick the best healthcare system, learn how to constructively fight to get what they want, and now interpret the new healthcare reforms that are going on. And so managed care was supposed to be about the equitable distribution of resources. I'm really down on managed care, as you can tell. And I give lectures all the time to these executives to try to get them to allow people with type 1 to get devices like continuous glucose monitors, which are not cheap. And I really feel like giving them a gesture at these meetings. They're sitting there, their faces are turning red. I know what they're thinking. You know, this is going to bust our profits. And the only slide I can show them get away with it is this slide, right? Is this one. This one. Diabetes is not a rare disease. It's not an inexpensive one. And then I show them this slide. Hope that was loud right here. Once again, if you look at the famous people with diabetes, look at this list of, I mean, once again, diabetes affects everybody. You could be a movie star. And I always like this one, Ray Kroc. And one conference, you know, I wanted to say he was the founder of McDonald's, and what came out was I said he was the founder of diabetes. And that went over pretty good. So some of the other workshops, and these workshops are really meant to get to their individual needs. I told you earlier that educating the type 3 diabetic, and I call them the person living or caring about someone with diabetes. This is a workshop just for the significant other. It's tremendous. Because these folks, if they're not educated and motivated, then trust me, it's going to be a bad situation at home because they're going to bug them. We call them the diabetic police. So, you know, my kids, and they always seem to be experts regarding my diabetes care. They'll say, "Dad, you can't eat that piece of chocolate cake." And I say, "Okay, watch this." And so one of the most important slides I can show you is the chances of a man winning an argument. The dating period is 50%. The engagement period is 30%. Of course, the marriage period goes down to 0. Now, after one of the conferences, a patient said to me, "Well, how does this relate to the animal kingdom?" So here's the dating period. There's the engagement period. Now, sorry for all you guys out there, but just to warn you, this is the marriage period. Now, we also offer, we get a bunch of podiatrists to do free foot exams. We get pharmacists to talk about medications. If you don't tell a patient about the drug they're taking, why it was prescribed, what it does, then they're not going to take it. They're going to look for some herbal remedy with a bunch of false claims from the vitamin store. We do eye screening, and we also talk about exercise. Anybody see anything wrong with this picture? And we don't just give lectures. We used to give lectures on exercise. That's boring. And who wants to hear about how exercise can make you feel better? We actually have activities at the conference in the afternoon. Tai Chi, Zumba, all kinds of stuff. And we tell people how to use pedometers. And that's one of the great motivational tools, because you can compete with yourself. You can build up every single day. This is my elliptical stepper at home. And you know, I belong to a nice gym. I go there once a year to pay the dues for sure. And this thing, I watch San Diego State BYU in the last game, you know. All right, for those of you that have to go, go ahead. I got about 5 more minutes. But this is how I use my stepper every single day. There it is, right there. Oh, there's non-alcoholic beer down here. We have a health fair. Health fair is really important to tell patients the latest and greatest. We have other not-for-profits show up. And we also bring the professional community together as well. You try to bring Duke and UNC together during basketball season. It's pretty tough. And we pretty much end the day with, and this is my last slide, with the motivational comments from the co-directors. And we try to leave people with some hope that they can actually do better with their diabetes. And also we set up a system with our membership program to stay in touch. We have a newsletter, we have a TV show, and we try to get them to leave that day motivated. And the big joke is they're so motivated at the end of the conference that they're actually happy they have diabetes. So thank you very much for your time and attention.
That newness to me is.
It's when you get more cautious about it.
It's when I get more cautious about it. When I'm, you know, and I think it's a different risk thing. I mean, if I had a history of cervical cancer in my family, and I needed my daughter to get it, you know, then that's a different decision. If it's, you know, if it's brand new and my daughter has, you know, we have no history or something like that, I'd be like, you know.
So you take the information, but it would definitely, family history would definitely impact whether you'd be more likely to take it or not.
Mm-hmm.
Yeah, if you had no family history, and the new thing you maybe hold back from it, right?
But like I said before, it's also the difference. I have no problem taking much greater risk than I would put on her or my kids, if you know.
Right. For you personally.
For me personally, risk is not a problem in my life, but putting risk on others is a problem.
When you're more conscious.
Like when you look at like my health history, or like the possibility of our son having more of my family's health history, it's different choices.
Interesting. What else do we need to write in this article? How can we decrease that anxiety? Go ahead.
I was going to ask, what are the trusted sources? We said pediatrics before, but like media-wise.
I don't trust any media. I don't either.
No, but I mean like